Good evening. Let's talk about amniotic fluid embolism. The real significance as a killer disease in 1941 when Steiner and Lusbach published autopsy series of 8 pregnant women who died of sudden shock during labor. This is called as anaphylactoid disease of pregnancy, that is amniotic fluid embolism. The shock is unexplained out of profession of bleeding. Very important statement in any questions you have to see properly. Then the definitions of amniotic fluid embolism, when you should tell it is an amniotic fluid embolism, there should be a sudden cardiovascular collapse, very important, plus altered mental status. Second, third one is disseminated intravascular coagulations. Okay, extremely high mortality rate, 80 to 90% in 19 to 72 and 30 to 50% now, due to the entry. How do the mechanism? Due to entry of amniotic fluid, fetal debris, fetal antigens into the maternal circulations. Remember, due to the entry of amniotic fluid, fetal debris, fetal antigen into the maternal circulation through the maternal venous channel in the uterus. Its incidence is very rare, 1 to 12 cases per 1 lakh deliveries. SFM, Society of Fetal Maternal Medicine criteria, Society of Maternal Fetal Medicine, they have to hold acute hypertension, less than systolic BP, less than 90 mmHg, or cardiorespiratory arrest, dyspnea, SpO2 fall, and cyanosis. Laboratory documentation, there should be a laboratory documentation of disseminated intravascular coagulations, and the typical onset should be during the labor or within 30 minutes of placental delivery. Remember the very important statement. Typical onset of amniotic fluid embolism during delivery, during labor, or within 30 minutes of placental delivery. You always have to exclude sepsis, absence of fever during labor, that is should not be more than 38 degrees centigrade. Then what is the etiopathogenesis? Simultaneous breach in the amniotic membrane and the vein wall in the uterine musculature. Remember, the simultaneous, there should be a breach in the amniotic membrane and there will be a breach in the vein wall of the uterine musculature. The opening of venous channel, the risk factors during the process of cesarean sections, instrumental delivery, placental abruptions, and placenta previa. These are the causes that increasing the risk of amniotic fluid embolism, cesarean section, placental abruption, placenta previa, instrumental delivery, simultaneously breach in the amniotic membrane and the vein wall in the musculature, opening of venous channels, increasing intrauterine pressures that forces the amniotic fluid, increasing in intrauterine pressure thus forces the amniotic fluid into the venous channel of maternal circulation. In case of polyhydramnios, because of pressure, remember polyhydramnios, another things, because of overuse of oxytocin, overzealous use of oxytocin, the repeated contraction increase the pressure of intrauterine pressure, that will cause forcefully drain the amniotic fluid into the venous channel of the maternal circulation. Then another thing, precipitate labor, very important. Another thing is eclampsia, okay. And another is male fetus. This is the exposure of amniotic fluid or fetal antigen, fetal debris, that will cause the immunological release of mediator, that may cause mechanical obstruction, that may cause complement system activations and coagulation system activations. These all three coagulation, mechanical obstruction, immunological, mechanical obstruction, complement system activations. These all three causes cardiopulmonary effects that cause acute pulmonary hypertension, hypoxia, and right ventricular failure. Then this coagulation systems activations, immunological, mechanical, complement system activation plus coagulation system activation. This coagulation system activation cause conjunctive coagulopathy. This all both cardiopulmonary effect and conjunctive coagulopathy both cause cardiopulmonary collapse and death of the patients. Left ventricular failure, neurological problems, coma, seizure disorder, residual deficits, acute respiratory distress syndrome, other organ dysfunctions like acute kidney injury, very important. Okay, the persistent neurological deficit, cardiogenic, non-cardiogenic, pulmonary edema, intrapulmonary shunting, bronchoconstrictions, desaturations, dyspnea, bronchospasms, cyanosis, and pulmonary edema. Okay, these are the mechanism. Bleeding out of the vagina, amniotic fluid enter into the maternal circulations, the venous circulations. Then there will be hypoxia, seizure, decreased coronary blood flow, decrease in inotrophs, decreased cardiac output, pulmonary congestion, hypertension, shock. Amniotic fluid enter into the maternal body circulation by intrapulmonary shunting, thrombin release, thromboplastin, disseminated intravascular coagulations, bleeding, that will cause bleeding. Then decrease in uterine uterine perfusion, hypoxia, fetal hypoxia, bradycardia, and fetal death. All of this very very important things. Okay, disseminated many mechanism, immunological release factors, mechanical obstruction, complement system activation, this cause cardiopulmonary arrest, followed by hypertension, hypoxia, and right ventricular failures, coagulation system, congestive coagulopathy, cardiorespiratory collapse, and death. Left ventricular failure, neurological problem, coma, seizure, residual deficit, acute respiratory distress syndrome, acute kidney injury. Okay. Then fetal squamous cell within the HPV, no specific diagnostic test. You can get fetal squamous cell in the maternal lungs. Very very important. Very very important. Fetal squamous cell within the pulmonary arterioles of maternal. The diagnosis, initial diagnostic evaluation should include continuous initial diagnostic methods. The initial diagnostic evaluation should include continuous pulse oximetry and arterial blood gas measurement to determine the degree of hypoxemia. ABG level, expected changes consistent with hypoxemia. There should be a decrease in pH that will cause acidosis, decrease in partial pressure of oxygen, increase in partial pressure of CO2 level, base excess will be increased. Then second thing is serial complete blood counts and coagulation studies should be sent to follow trends, detect early coagulopathy. Serial complete CBC and coagulation study should be sent to follow trend and detect early coagulopathy. CBC with platelets, hemoglobin and hematocrit levels should be within the reference range. Thrombocytopenia is rare. Prothrombin time and APTT, activated partial thromboplastin time, PT is prolonged because of clotting factor are used off. Values are institution specific, but interventions is indicated when the PT is 1.5 times the control value, that INR is more than 1.5 times. APTT may be within reference range or certain. If available, fibrinogen should be monitored. Okay. The four things, blood type and screenings in anticipation of the requirement for transfusion should be done. Chest radiography in a posterior anterior view or lateral finding are usually non-specific. The chip radiographic abnormality in the amniotic fluid embolism are diffuse bilateral, remember diffuse, listen, there should be a both lungs, it will be there, diffuse bilateral, heterogeneous, diffuse bilateral heterogeneous and homogeneous area of increased opacity which are indistinguishable from the acute pulmonary edema. Very very important, very very important. A 12 lead ECG echocardiogram may show tachycardia and ST segment 2 of changes and finding consistent with right ventricular strain pattern. You have to do a echocardiogram. ST segment 2 of changes. Differential diagnosis, there can be anaphylaxis, aortic dissections, cholesterol embolism, myocardial infarctions, pulmonary embolism, septic shock, IR embolism, eclamptic convulsion and coma, convulsion from the toxic reaction to local anesthetic drugs, aspiration of gastric contents, hemorrhagic shocks in obstetric patients. Okay. Anaphylaxis, aortic dissections, cholesterol embolism, myocardial infarctions, pulmonary embolism, septic shock, air embolism, eclamptic convulsions, coma, convulsion from the toxic reaction to local anesthetic drugs. If you see the questions, anywhere in the question, if they have mentioned unexplained shock, sudden onset within 30 minutes during the delivery or within 30 minutes of placental delivery, violent uterine contractions, sudden onset of DIC, these are all the clue point for amniotic fluid embolism. Remember, unexplained shock, sudden onset, violent uterine contractions, sudden DIC. The management, there is even no specific drugs or antidote. The aim is to correct the physiological abnormality like hypoxia, hypertension. The IC should be managed in a well-equipped ICU with a multidisciplinary team. There should be a continuous ECG and SpO2, urine output and central venous line, arterial line to check blood, ABG gas, use IV fluid very carefully. Remember to maintain urine output to up to 30 ml per hour and central venous pressure 30 ml per hour. CVP has to be 10 centimeter. If PCL pressure of oxygen is less than 65%, if it is less than 65%, then you have to intubate the patient, ventilate to maintain optimal oxygen saturation. If hypotension is not getting corrected, start norepinephrine infusions. If ongoing bleeding and activated massive ongoing bleeding will be there because of DICU, so you have to start massive transfusion protocol. Urgent delivery after correction of the coagulopathy.